All right, guys. Thank y'all so much for coming tonight. Looks like we've got a good turnout here, about 130 people. So I'm going to go ahead and get started. And if we've got any late joiners, they can hop in late to the party here. I'm Max Seiter. I'm the newest surgeon here at VSON Orthopedics. I'm sports medicine fellowship trained, and my focus here is complex shoulder, hip, and knee surgery. The topic of tonight's webinar is knee pain and just when should I be evaluated, because I try to keep these webinars a little more general. I think that's probably the highest benefit. Lots of people tweak the knee up on the mountain during the season, or maybe have been living with some knee pain. And, what are the alarm symptoms? What are things that you should come see me for? Let's get started. So the knee is the largest joint in the human body, and it's the most easily and commonly injured joint. That's particularly true in a ski community. About 30% of ski injuries are knee injuries, which is about twice as much as any other joint in the body. Over 5 million people a year come to orthopedic surgeons for knee injuries, and that's in the US. And knee has relatively complex anatomy, although it is just a hinge joint. There's a lot of working components within there, and the knee bears all of your weight-bearing force. So it is, if it is injured, it's vulnerable to continuing pain, functional issues, etc. Normally, injuries that we see about the knee are either a very forceful trauma or kind of a atraumatic twisting mechanism in which ligament may tear or something similar to that. Degenerative means also common. That's normally like a little wear and tear, maybe some early arthritis, or maybe some tendinitis. So common causes of knee pain, and over on the right, there's a little diagram showing some of the structures about the knee. More common with a big injury is a fracture, but ligament tears, also very common here in this area where we live. Meniscal tears, probably one of the more common things that I see patients for, whether it's acute or degenerative. The menisci are like the cushions of the knee. Cartilage injury can also be acute or a wear and tear type process. Tendinopathy is just a fancy word for saying that you have some inflammation in your tendons and maybe a little degeneration of those tendons. Tendinopathy closely accompanies bursitis, which is inflammation in the little sac beneath the tendons that allows smooth gliding of the tendons. They generally run hand in hand, and those are the things that we're kind of giving people steroid injection for around the tendons. Bone bruise is the fracture's younger sister. So it is when you've had a big trauma to the knee and you almost fractured, and you have actually what we call a bone bruise technically is a microtrabecular fracture. The way that I describe this to patients in clinic is that bone is kind of like a M&M. You've got a hard candy coating with a softer center, and a bone bruise is actually like a little fracture of that inner soft center without injuring the outer cortex of the bone. So there's no instability, but it can really lead to some nagging symptoms and can take you out of the things that you like to do for several weeks to months. Knee inflammation, I've kind of grouped arthritis into there because arthritis, when arthritis becomes symptomatic, it is due to the inflammation within the knee from the loss of the smooth bearing surface of the joint. So lots of different ways of looking at knee pain, and just one of the ways that I've chosen to focus on here is whether it's inside or outside the joint. We also, of course, look at which side of the joint it is, but that this is one of the initial things that we focus in on. So intra-articular, meaning inside the joint, is things such as the menisci, the cruciate ligaments, the ACL and the PCL, cartilage, or bone, because you do have bone within the joint, but the cartilage is the smooth coating of the joint surface. And synovium is the inner lining of the joint capsule that can become very inflamed. And If you have a problem inside the joint, the synovium generally reacts to that and causes a lot of pain. Also, you can have what's called a Cenobitis, which is kind of in that inflammatory catch-all of knee issues. Outside the joint is where we are focusing on tendons being the problematic thing, that there's only one tendon that runs inside the knee joint. It's called the popliteus tendon, whereas your hamstrings, your quadricep, your patellar tendon are outside the joint. And these can be bad actors when it comes to kind of nagging injuries about the knee. The collateral ligaments, which provide the knee with stability in this direction, are commonly injured with a ski injury, and we'll kind of get a little more into that here in a second. But they're the sisters of the cruciate ligaments and are the stabilizers of the knee. Bursa, as I said, is the smooth sac underneath tendons and can become inflamed when you're having a tendinous issue. Bone, of course, you can have bone issues outside the joint that are just close to the knee, fracture or a bone bruise out there. So when you're coming into clinic here, it's essentially, what are we doing? What's the benefit of coming in? So things that I will obtain is a detailed history, right? And this is almost 2/3 of the visit, that really figuring out what's going on from your own mouth, right? Patient isn't just an MRI. I need to hear from you exactly what happened and how's it bothering you? What's it bother you most with the activities that you're doing? And what exactly is the quality and nature of the pain that you're having? Physical exam further narrows down exactly what the problem at hand is. And these two components are actually the real bread and butter of what we do. We've got a lot of fancy technical things to really get a diagnosis, but 99% of people that I see, I have a pretty good idea of what's going on just based off these two things, whether something is a meniscal tear, you have a ligamentous injury, there's a possible fracture, etc. Imaging, so we're an orthopedic office. Every patient essentially gets an x-ray because we got to know what's going on with the bone. MRI for something that is probably a soft tissue issue. A CT scan is how we look at bone in more detail. If you've ever been unfortunate enough to have a tibial plateau fracture, you're probably familiar with the CT scanner. And ultrasound for some other more niche type issues. Thought this was a nice little graphic here, but these are kind of the really alarming things that, oh gosh, I should actually, rather than waiting to see the doctor, maybe I should go to the urgent care that we have open from 11 to 7 every day. If you injure your knee and you're having rapid swelling, if there's a obvious deformity or instability about the knee, you cannot place weight, you had a big popping sound when the injury occurred, these are things that probably should be checked out almost immediately. The loss of range of motion, we generally see about the knee with any amount of swelling in the knee, that particularly getting deep flexion is very painful for people. And then we always worry about people getting extension back. But mechanical symptoms are generally something you'd notice over a more chronic type injury, some clicking, popping, catching, locking of the joint, and that may be indicative of a meniscal tear or something going on within the joint. Weakness could be associated with a tendon tear, also could be associated just with something else going on inside the joint that's causing like the quadriceps muscle to shut down, which is something that's very common with all knee injuries. So getting into a little more detail on each of these fractures of the knee. So there's 4 bones that are about the knee. The tibia, the femur, and the patella are the knee proper, and the proximal fibula is the small bone in your leg that is pictured right there, that is knee adjacent. So these are generally pretty obvious when they occur. Normally there's a significant trauma, severe pain, swelling, cannot weight bear, and there may be some instability about the joint. What I've pictured up here is a tibial plateau fracture. This is probably the most common skier's fracture, and I will probably fix on a busy week somewhere about 5 to 7 of these a week. The close sister, as I was saying, of these is a bone bruise. So with a tibial plateau fracture, you've punched the femur down into the tibia and really fractured the bone right there, right? Like where my arrow is should be a joint line, and that joint line has been depressed down. And then we've restored it up very nicely up here, giving a nice anatomic restoration of the joint. Here, that fracture didn't happen, but you have this microtrabecular fracture, which is just a big contusion within the bone, or a small microfracture within there, which can really cause people to have a delayed return to sport, etc. Just kind of a nagging injury that is a non-surgical thing, but takes a while to heal up. Generally, fractures are things that you're not questioning whether you should come see a doctor. You are either taken in by a toboggan, or you willfully take yourself in because you know something's wrong. The meniscus is probably something that you live with a little longer. You're a little curious, what is going on with my knee? Why does it hurt? Every time I twist my knee, I feel a little pop or a little pain, and I may have had this going on for a while, and knee just doesn't feel quite right, and it hurts. So you have two menisci within the joint, the lateral meniscus and the medial meniscus. The meniscus function is to cushion the knee. So when you are walking, the menisci are right there. It cushions the cartilage with that compression there. So the menisci are very important for the preservation of your overall knee health, that it protects your articular cartilage. And as sports surgeons, we love your articular cartilage. We want that to be preserved for your whole life, so you never have to meet our counterparts, the joint surgeons who do the joint replacements. Meniscal preservation is the name of the game in my knee practice. So normally a meniscal tear is either acute or degenerative. With a big twist of the knee, there may have been a pop of the meniscus there that causes a large tear. And those are generally repairable tears. Wear and tear type tears, generally we get as we age a little bit. We have an active lifestyle. We've been using the knee and doing all the fun things that we like to do. And eventually that meniscus just has a little give in it that causes a tear that is creating symptoms. Generally those symptoms are pain with range of motion, particularly deep flexion or deep bending of the knee, weight bearing, and a twist with weight bearing may bother the knee, and intermittent swelling may occur around the knee as well. Mechanical symptoms are not present all the time with meniscal tears, that clicking, popping, catching, or locking of the knee. But when we do see those symptoms, we really start to hone in like, this is probably some meniscal pathology. Meniscus injuries are very common with other injuries about the knee. Almost all the ACLs that I reconstruct have some degree of meniscal injury, but not all of them need a meniscal repair, that some of those do heal on their own. So what's the treatment for meniscus? Do nothing is always an option in any knee, but generally that's not the best option. But repairing the meniscus or trimming out the meniscus. So a meniscal repair, we place sutures through the meniscus, and this is generally what we're doing for acute tears or tears that have a particular pattern that we know is repairable. A tear here can't really get a good repair on this, and this part of the meniscus, the inside of the meniscus, doesn't like to heal. We just treat this with a little meniscal trim, taking out that portion of the meniscus that's damaged and removing the pain generator there. Ultimately, we like to preserve the meniscus as much as possible. That preserves your long-term knee health and helps protect some of the stability of your knee. But again, sometimes we do just have to do a little trim, and results are great on that. But if we can repair it, we like to. And one note on this, some meniscal injuries are time sensitive, that if you are having some of these symptoms, this is one of the things that I actually do like to treat earlier rather than later, because if you have a big tear and that tear is flipped out into the joint, that meniscus can become so damaged that it's not repairable. Or if you have a tear where the meniscus attaches to the tibia, then you lose the competency of the entire meniscus and you can wear out your cartilage actually quite quickly. So these are one of the things that I wouldn't necessarily call them urgent, but I think, you know, if you think you maybe having something like that going on, knowing is better than not knowing. The ligamentous injuries, so these are the classic ski injuries. The ACL MCL combo is the most common ski injury out there. So ACL, MCL, LCL, and PCL are the primary knee stabilizers. The ACL protects the motion of the knee coming in this direction. The PCL protects coming backwards, and the collaterals protect with that. So these generally associated either with a trauma or like these are very common, like basketball type injuries, a non-contact twisting injury where somebody feels a pop. At that point, knee will swell, may not be able to bear weight, but the symptoms actually may be pretty minimal. I've treated a couple patients in the past month who did not know they had an ACL tear. They just had a kind of something weird happen, and they came in and saw me and got an MRI exam. They felt loose, got an MRI, and there's no MCL or ACL left there anymore. Instability is the big issue with these, right? That when you have a ligamentous injury, the knee isn't stable, so you don't have the normal restraint. You're rubbing on the cartilage in an abnormal fashion, and that meniscus is seeing forces that it shouldn't see. So having particularly an ACL deficient knee is what has been most well studied, can lead to further cartilage damage and meniscal damage, which may or may not be repairable. Mechanical symptoms, again, lots of meniscal injury associated with ligamentous injuries. So normally when we're seeing mechanical symptoms with an ACL, it's indicative that there's something with the meniscus there as well. Not uncommon to have other injuries with a ligamentous injury. Usually it's other ligaments, and then that's a multi-ligamentous knee, which is a pretty big time injury. So how do we treat these? Generally, we treat a ligamentous injury with either a reconstruction or a repair. ACL are not amenable to repair. So we reconstruct, meaning we take out the old tissue and put in new tissue to reconstruct that ACL with a new ACL there. So here you see a picture down here of a reconstructed ACL. This was done with a donor graft, cadaveric graft. And here's a couple different areas where we take graft from in order to reconstruct an ACL. Most people here in our community, I generally recommend using their own tissue. There's a 4 times higher rate of failure when you use allograft, which is donor tissue, versus using your own tissue. That's because your own tissue integrates better and you have a better new ACL. In somebody who's less active or does not want to have their own tissue taken, then in that population, I'll use donor tissue. Different from the ACL, the collaterals generally heal very well without operative intervention, especially if it's an isolated MCL. That has the best healing potential of anywhere around the knee. You yourself or somebody close to you has probably had an MCL injury in the past 5 years and has done fine being treated non-operatively and is now back doing everything they were doing before, no pain, totally stable knee. Once we get into this multi-ligamentous type injury where the ACL is injured and the MCL is injured, that's when we kind of come into a gray area and we talk about trying to let the MCL heal and then reconstructing the ACL or doing both based on the amount of instability that we see around the knee. So this is something that if you have a ligamentous injury, you should definitely come in and see myself or one of my counterparts that this is something that you need some expertise to really know the best route of treatment on these. I think that just saying, no, it'll be fine is maybe not the best course of action. Cartilage pathology. So this is truly complex knee surgery when you're treating this in a sports fashion. So cartilage is the smooth bearing surface of the joint. Cartilage is what allows our joints to glide and function as they do. It has a very low coefficient of friction, and this allows the smooth motion of all of our joints. When you hear somebody say, I'm, quote, bone on bone, that means they've lost all their cartilage and they are now rubbing bone on bone. It is possible to have diffuse cartilage wear, where there is no cartilage left on the joint, or a very focal cartilage wear, which is generally from a traumatic etiology. So here we see a very large cartilage lesion as seen underneath the arthroscope. An arthroscope is the camera that we put into the joint. So with this sort of lesion in a young person, we really want to make every effort we can to preserve that joint. So generally the way I'm treating these is first we get an MRI, right? So here you can see a couple MRIs where there's some cartilage defects right here. And these things, we first go in, we scope the knee, we get a good look at the cartilage, we clean it up, and about 40% of those people do not need any other further treatment, that they feel fine and they don't want a big procedure. The big procedure that we do is a cartilage transplant, where we drill out this defect here and replace it with a plug of cartilage and bone, and allows that to integrate into new cartilage. I actually didn't include a picture of that here, but what we do is core out this cartilage defect and then replace it with juvenile cartilage in there. That gives you a nice new smooth bearing surface in that focal injury. If you have diffuse cartilage wear, that is the time when we start talking about steroid injections, and then ultimately a joint replacement if needed. And the general symptoms of cartilage pathology are pretty vague. That recurrent swelling, maybe some focal pain, maybe some global pain around the knee. You may lose some range of motion, may feel some mechanical symptoms, that clicking, popping, catching, because that smooth bearing surface of the joint has been worn away. If you have malalignment, either bow-legged or knock-kneed, you are at risk for having cartilage wear there. So that is one of the things that we key in on, and we get alignment films to actually take a good look. What's the bone structure? Are you at risk for wearing the cartilage? And if we replace that cartilage, is it going to be successful, or do we need to add on another procedure in order to treat that malalignment? Most people will have a remote history of injury with a cartilage lesion. Like, oh gosh, yeah, I had a really huge fall 5 years ago, knee swelled up for about 3 weeks. It was kind of fine afterwards. And now I've just had this nagging, intermittent swelling, kind of some clicking in the joint, those sort of things. Here's a picture of this bone plug that I was mentioning. So cartilage up top, subchondral bone, which is just very hard bone, and then that trabecular chocolate center bone down there. So drill out the cartilage lesion and replace it with that. The malalignment we can treat actually. So this person is bow-legged and had a treatment with an osteotomy. They actually have frank arthritis here, but in a attempt to preserve the joint in a young person, we will realign the joint so that we're offloading that problematic area of the knee and delaying the amount of time until you need a total knee replacement. Generally, people get a solid 10, possibly 20 years out of an osteotomy surgery before they need a joint replacement, which is a great option if somebody's 30 years old, because doing a joint replacement in somebody that young actually the joint will wear out, and then there's much larger surgeries down the road, which is why we generally say we don't like doing joints in young people. And then again, as most orthopedic issues, another option is non-operative treatment that We never force surgery on anybody. Tendon injuries and bursitis, very common, and probably much more common than any other injuries, but not the most common thing I see in my practice, because a lot of people just kind of live with these sort of things. No, yeah, I've got a little muscle pain here and there, and I treat it with some ibuprofen at home. So around the knee, the most commonly symptomatic tendons are the quadriceps tendon, the patellar tendon, the hamstrings, and the iliotibial band. My wife likes to call it the T band. Without a full thickness tear, these are 100% treated non-operatively and respond very well to physical therapy. This is something that Olivia is doing all day long and helping people with these sort of issues. These can be associated with a possible traumatic injury, but commonly wear and tear type things. Maybe people are more common with this in the shoulder, with the rotator cuff tendonitis, that sort of thing. But tenderness directly over the tendon, pain with stretching the tendon or actually actively using the muscle that the tendon is attached to, may have some focal swelling over the tendon, but maybe no swelling associated, and maybe some weakness that you may actually have some shutdown of the muscle because of the pain. Or if there's a full thickness tear, you will certainly have weakness because you've lost that attachment of the tendon to the bone. So how we treat tendon tears is by suturing the tendon back down to bone with very high strength sutures and taking off a little bit of that outer candy coating of the bone to expose the very nice healing center of the bone for that tendon to heal back down to. Generally, tendinopathies, meaning just tendon inflammation or a little tendon degeneration, respond very well to non-operative treatment. Physical therapy is the crux of treatment for these, but we do use adjuncts like steroid injections or PRP injections. PRP is a biologic that we get from your own blood and can inject into the tendon to induce a healing response or an anti-inflammatory response there. Occasionally, and very rarely, some of these degenerative tendon issues will persist, and these may require surgery, such as if you have really recalcitrant patellar tendon inflammation, you've done everything, you've done all the PT, you've tried some injections, then we go in and debride, meaning just take out a little bit of that degenerative tendon and induce a healing response by taking out the degenerative tendon and sewing the good tendon together. And that has good results, but very few people end up needing that because these do respond so well to non-operative treatment. This has been a 50,000 foot overview. And of course, there are other complexities about the knee that are things that we would talk about if I discover them as seeing you in clinic. But when should I see a doctor? And sorry, this is such a wordy slide here, but knee joint's complex. And if you are having bothersome knee pain, you should just come in and see us. Half of what I do is reassurance, right? You know, I'm a surgeon, but I am a diagnostician and a reassurer as well. That there are many things that can be treated non-operatively, and I myself, with orthopedic issues I've had to have surgeries, and then I've also had things where I'm like, okay, good. Knowing is half the battle. And I just wanted to know that, oh, I'm not wearing this certain thing out and I can continue to do the activities that I'm doing. But like if you are having some of those alarm symptoms, can't weight bear, severe swelling, severe pain, had a big trauma with like noticeable pop, instability, you should seek care immediately. If you have had an injury in the past or just gradually noticing the knee feels unstable, there's some mechanical symptoms, things just aren't quite right, it's having occasional swelling, or you're having some intermittent pain with activities, you should definitely consider scheduling an appointment, because we can figure this out for you and, you know, either give you peace of mind, or if it's a surgical issue, prevent further damage to the knee. Many injuries are treated non-operatively, and again, diagnosis and reassurance is half of what we do. So what to expect in the visit? Again, a history, asking you exactly what happened, figuring out exactly what's going on right now. Thorough physical exam really elucidates things. And then plain x-rays are pretty much a standard for any first visit, but not necessary for all problems. If it's a pretty clear tendinitis, then we can normally skip the x-ray. Based off these, we discuss a plan of treatment. If there is something concerning that I think maybe this is a surgical problem and we want to make, or, you know, we want to rule out a surgical problem, further imaging, normally an MRI is indicated. Non-operative management with PT, bracing, possible injections. And if there is indeed a surgical issue, talking about a surgical treatment. So thank you for your attention here. I'm going to flip it over to Olivia here for a bit, and then we'll open it up to questions afterwards. All right, Olivia. Oh, I think you're muted, Olivia.
Thank you. All right, let me share my screen here. All right, so knee pain and physical therapy. So as Dr. Seiter mentioned about getting a history and evaluation, we as physical therapists can also do the same thing for you. So we're looking at the same things. What type of pain are you having? Where is your pain? What makes it feel better? What makes it feel worse? Have you had any other knee pain or issues before? We're also doing an evaluation where we're looking for any swelling or bruising. We're palpating for any tenderness or pain that you may have in these areas. We're assessing your range of motion, your strength, and we're using special tests to look at, is it your meniscus? Is it your ligaments? What's going on? Is it a tendinitis or a tendinopathy? And then once we make our decision of what we think may be going on, we can refer you back to an orthopedic doctor for further examination and imaging if we think that may be necessary or needed. And how can a physical therapy help with my knee pain? So Dr. Seiter mentioned there's two different ways to address knee pain, operatively and non-operatively. So non-operatively, we can help to relieve some of your symptoms that you're having, such as your pain. We can decrease your swelling and inflammation, work on your range of motion to get in strength, improving your balance to get you back to your prior level of function in your activities that you like. If you're less fortunate and have to undergo surgery, we can also treat you there. So we can treat you before your surgery for some prehab, and also after your surgery. Before your surgery, we want to get you in basically like tip-top shape to promote a more successful outcome, where we're working on regaining any range of motion that you lost from that injury and improving your strength. We can practice with any equipment that you may need. If you're going to need a knee brace after surgery, we can practice putting it on, taking it off, how to lock it, how to unlock it. Or if you need crutches or a walker, we can help fit you for those and teaching you how to use those. Then we can also just educate you on what to expect with your rehab and your surgery. That way you're going in with more knowledge and more confidence and a better understanding of what to expect. And then after surgery, it's the same thing. You know, we're working to get you back to your usual life and your hobbies, because ultimately that's what you want. That's why you went and had surgery in the first place. So some techniques that we use here, dried needling is a favorite. I absolutely love it. I use it. Most of our therapists also as well. It really works well with any tendinopathies, any muscles that aren't doing their job properly or are too tight and restricted. And same thing with therapeutic cupping. Both techniques I really promote and use on a daily basis myself. We also use some blood flow restricted therapy, some instrument assisted soft tissue mobilization, kinesiotaping, ultrasound, electrical stim, massage, and our Breckenridge Clinic has aquatic therapy for pool therapy. And then also we make custom sole support orthotics. And just in case that you need reminded, if you have any questions about your knee pain and where you should go or what you should do about it, these are some important things to remember. So a large injury where you're struggling to put weight through your leg or have severe swelling and pain, that's when you should go get treatment immediately, which you can go to our VSO urgent care that's open 7 days a week. And then if it's more of a chronic injury or something that's just gradually increasing, your knee may feel unstable or you're having that clicking or catching, popping sensation that Dr. Seiter had mentioned, or your pain isn't terrible and you're still able to do the things you like, that's when you consider scheduling an appointment. Physical therapy, we can get you in and get you in the right direction, and or going to see that orthopedic doctor as well. We have 3 locations at Avalanche. We have our Breckenridge Clinic that's located at the Rec Center. Our Frisco location that's actually attached to the VSO office. And then our Silverthorne location that's on Adams Avenue that's right before Target. And I want to thank you for listening to Dr. Seiter and I. We appreciate you and look forward to hearing from you and answering any questions that you may have. Thank you.
Thanks, Olivia. So thanks for tuning in, everybody. This is actually my favorite part, is kind of going through the questions on these. I think Rachel was going to read these out, but Rachel, I've been able to pull up the Q&A here, so I will just start running through them if that is okay with everybody here. So I'm just going through them in order of time here. Jennifer, I see that you had an x-ray of your knee and your joint is bone on bone. You had a cortisone shot, and what are your options? When you're bone on bone, that is generally somebody who has frank arthritis, meaning you have diffuse cartilage wear. It's not something that we treat with like a cartilage replacement. The first option, again, always is you can continue to go with non-operative management with further cortisone injections, possibly a hyaluronic acid injection, which is if you've heard people say, I've had a gel injection in my knee, it mimics the lubricating fluid within the knee. And some people respond very well to it. Some people are like, that didn't work out so great. Let's go back to the steroid. And then surgical options, depending on where the wear is in the knee, that you can potentially be a candidate for a partial knee replacement versus a total knee replacement. Partial knee replacement is if there is very focal wear, but it is global, that we replace just that one compartment of the knee. Whereas a total knee replacement is if the wear is all through the joint, or if you have some wear on one side of the joint, but you're having pain on the other side of the joint, and we don't think that a partial knee replacement is going to be successful for you, we take out the arthritic bone and replace it with a smooth bearing knee model with new metal to give you a new, nice, smooth bearing surface, a tibial tray, which is made of metal, and then a plastic insert, which actually gives the stability to the knee, and we size that up according
He's back. You're muted still.
Sorry, I lost my internet connection there for a second. As we get like 50 or older, we're very comfortable replacing people's joints, but younger than that, there are options for joint preservation with osteotomies, which is kind of complex and is something we would discuss in clinic. So I see Gail has had 5 surgeries on the knee, and 1 year ago, you did not have bad enough arthritis to warrant a knee replacement, but it's been interfering with your life, skiing, and when is it appropriate to go for it? And you'll be 65 soon. So one of my party lines in clinic is that the only indications for a knee replacement are pain and loss of function. That the x-rays are a diagnostic tool that we use, but again, taking from the patient is the most important thing, right? So if you are having a lot of knee pain, I don't think it's unreasonable to consider a knee replacement, that the outcomes are very reliable. Sounds like you've been through the ringer on this knee already. And that, I think it honestly, the story that you're telling right there, I think it's pretty appropriate to just go for it. There's also nothing wrong with trying some injections, seeing the sort of relief that you get with those, continuing with some PT. But those things, the story that you're telling there, you would meet my indications. Tom, so I see you had a medial meniscus surgery several years ago. 35 and 45 years maybe, and can that lead to knee pain in the later years? So a little bit of a complex question, and without knowing a little more information, the answer is yes. That we repair the meniscus to try to preserve the knee health, right? So if the meniscal surgery was a meniscus repair, hopefully that was successful and that meniscus healed and you're kind of back to normal anatomy. If the meniscus was trimmed, yes, you've lost some of that cushion in the knee, and there's nothing wrong with having a meniscus trim. It's just something we have to do sometimes with particular tears. But we do know that losing some of that meniscus leads to abnormal contact forces of that cartilage and can lead to some more advanced wear of the cartilage. So generally the answer, I guess, would be yes, but it does not mean that you will have knee pain later in the year, senior years. Many people have had meniscectomies and lived their whole life without ever needing a knee replacement or having any further symptoms in the knee. So I see Ron is interested in gel injections for patellofemoral joint inflammation. Come on in. This is something that's a very common reason to have a gel injection. And you may have a little wear underneath the patella there or in the trochlea, which is the groove in the cartilage. This is a very good indication for a gel injection to kind of lubricate that knee and hopefully get things moving smoothly and painlessly. Michael, for a bone bruise, how long is it typical for the pain to disappear? As a 63-year-old regular skier and hiker who injured the knee in early September with a twisting motion, that pain is diminished somewhat and is troublesome. MRI showed no meniscus damage, and wondering if it's a bone bruise. That's a long time for a bone bruise. So I would recommend coming back to clinic. There are going to be some aches and pains as we get older, but if the knee is really bothersome to you and you had an injury and it's still troublesome, I think it's a reason to come in for a repeat evaluation. That I think getting a good physical exam would elucidate some of these issues. And I don't think it's a bone bruise at this point, because I would expect that to have resolved. An MRI may still show evidence of a bone bruise, but clinically a bone bruise symptom should be pretty much resolved at about 3 months. And that's a more lingering type bone bruise. Gosh, that's 6 months, 7 months. That's a long time. So I would come back into clinic and let us get another look. Anonymous, I have a metal implant that precludes most MRIs. How much diagnosis can be done without an MRI? A lot. That we use the MRI as the final tool in diagnosis. The history and the physical exam are the elegance, I guess, of being a doctor, essentially, that you should have a pretty good idea of what is going on before jumping to these imaging. Although we like to get an MRI to confirm things, there are other tests that we can order depending on the problem at hand, and we'll normally have a pretty good idea as to what the issue is before ordering an MRI. The MRI is the confirmatory test. Ron, can a partial ACL tear repair itself? So yes and no. I hate to vacillate like that, but probably it's not going to heal itself. Maybe there may be some amount of healing, but one of the big questions about ACL, which is one of the most commonly published on topics in orthopedics, is how many fibers of the ACL do we need intact to have a functional ACL? Probably the most famous partial ACL tear was Ryan Tannehill's tear. He's the quarterback for the Miami Dolphins. He had a partial tear. They got him back out on the field a couple weeks later. Boom, tore the whole thing. So he didn't have enough fibers left. But I think I'm a big fan of shared decision making. And if you come into the clinic and you have a partial ACL tear and it looks like it's pretty bad, I will say, I will reconstruct this for you, that you're probably going to have some normal knee stability right now, but you're probably going to tear this all the way through at some point. And it's not unreasonable to go ahead with the reconstruction now, if that's what you're ready for and that's what you want to do. Also, I am happy to get you an ACL brace, and let's see how you do. And if you tear it all on your own, well, then we're just going to reconstruct the ACL anyway. So I think that is frustrating as a patient, not having like, okay, the doctor told me to do this or anything like that. But I think that's in your best interest, kind of like, okay, well, I can live with this. And if it goes all the way, I'll have it fixed. And if it's 95% torn, yeah, that's a reason to have it fixed. But if it's 50%, well, let's see how it goes. Maybe it never tears all the way. It probably will, but you can wait until that day happens. So yes, it may repair itself or it may not, but you may have enough fibers there that it is functional. Quinn, I see that you had a hip resurface about 2.5 years ago, and your knee gets sore easily after that procedure. Are these related? And you are 60 and very active. Yes, I think these definitely could be related. Normally, I would expect your knee pain actually to improve a little bit after a joint replacement because your kinetic chain is back in line. You've worked with Olivia. They've gotten everything going back normally, just like we like, right? But maybe your activity has increased since you've had the hip replaced, that if the hip was a big limiting factor for you, you're doing more and you had a little bit of pathology in that knee that's now rearing its ugly head. So in that sense, I think they are likely related. And I think it's worth having it checked out because there are many things that we can do for this that are not a joint replacement that may give you some better quality of life and doesn't really cause you any problems, or such that the knee doesn't cause you any problems with activity. So I would recommend just coming in and seeing one of us in here. Rachel asked, is juvenile cartilage synthetic material or donor material? So it is donor material. It is as it sounds. It is cartilage from a young patient. And the reason we choose young patient cartilage is that is the best quality cartilage, right? There's been no cell senescence, which means cell death. That all the cartilage is nice and thick and intact, and just beautiful, smooth cartilage there. And we can get a nice plug there that may outlast your own native cartilage. There have been attempts with donor material. They have been unsuccessful. There are certain cartilage procedures where actually we take your own cartilage and grow it out in a lab up in Boston and then have it sent back to us when you are ready for the big cartilage procedure. And there are some times where we will just take a little cartilage from the non-weight-bearing portion of your own knee and plug it back into your weight-bearing portion where you're having a symptomatic area. Generally, that taking the plug from one side of the knee and putting it in the other is for small lesions, right? Because you can't take too much cartilage from this area of the knee without getting in and creating a defect somewhere else. And the cartilage that we grow in a lab, we normally use on the undersurface of the kneecap because the outcomes are best there. For the medial and lateral compartments on the tibia and the femur, they do not do as well with that. And we like the juvenile cartilage for that. Sam, what is pain under the patella? Or what about pain on the patella feels like grating on the underside of the bone? That sounds like patella pain to me. So very common thing that sounds like you're lacking some cartilage underneath that patella. Many factors go into the decision for treatment on this: age, your desires, what you want to go through. The first steps that we normally do are, again, non-operative intervention. Therapy, because the quad is so related to your patella that getting that quad strong, getting the VMO, which is the quadricep muscle that's on the inside of the knee, getting that nice and normal and strong, and having that patella track as it should in the groove, which, and it's going to be kind of hard to show on this model, but that patella, I'm showing you the knee upside down, should track in that groove. If it's off, that causes abnormal wear on the cartilage there. So we really got to get this quadricep strong so it's pulling that patella into the position it should be in the groove. So the mainstay of treatment for initial management of patellar problems is therapy, because the outcomes are really good. It can take a while because it takes a while to get that muscular strength back. But once it does come back, it's quite effective. If there's a big cartilage problem, though, that's when we start talking about these kind of complex cartilage procedures, or something less invasive. Let's give you an injection and see how you do. Or maybe a partial knee replacement where we replace under the knee and replace that with metal and plastic to give you a smooth surface there again. So a lot of different factors in there. And this is something that, I break down when I see you in clinic. Hey, how old are you? What are our desires here? What level are we trying to get back to, et cetera? What do you want to do? Do you want a big surgical procedure, or do you not want surgery, or do you want an injection to try to treat this pain, or are you injection averse? So that's something we would all hammer out in clinic, and these are conversations I have all day long. Anonymous, where do you get the bone plug from dealing with articular cartilage problems? So I kind of touched on this here, that either from the donor, from your own bone, or grown out in a lab. And when we grow it out in the lab, we're just growing out the cartilage, not the full bone plug, which is why it doesn't do as well in the weight-bearing compartments, but it does well underneath the kneecap there. And some people do not want donor bone, so then we use their own bone, or we grow it out in the lab. Karen, I see that you are 55 and you are a collegiate tennis player turned marathoner. 40 marathons, congratulations, that's awesome. That you are bone on bone in the right knee, that's not awesome. And that you've had steroid shots, orthovisc, and a scope. So you've jumped through the hoops. You've got grade 4 osteoarthritis, and are you a candidate for a cartilage plug? Unfortunately not. That you have diffuse cartilage wear there. So that's when we talk about doing the partial knee if it's just on the inside, or doing the total knee, which is probably what I'm guessing is going on inside there. That you probably have what we call tri-compartmental arthritis, meaning all 3 compartments of the knee. Sounds like you'd be an excellent candidate for a joint replacement if you are ready for it. But again, this is something that we could hammer out in clinic if you are seeing myself or one of my partners. But cartilage plug, the longevity wouldn't be worth it. that once you get to a certain amount of wear and a certain age, we have a great procedure for you, and it's a joint replacement. And our goal when we do a joint replacement is to make that the last surgery that you ever need in your life on that knee. So I think at this point, you could be there. Rosie, regarding meniscus tears, you have had meniscus tears in both knees. One knee, 1 year, one knee in the next, but a month of PT suffice to get rid of all the pain. Awesome. You haven't had pain for several years now, and you read a study indicating that 2 years out, results for PT versus partial meniscectomy were the same. Any thoughts on when PT might be the better approach? Or in any case worth trying first? Yes, I have lots of thoughts on this. So the study that you probably read was a study that was a great study. It's one of the few randomized controlled trials in orthopedics, which are the highest level of evidence. So in this surgery, in this study, they actually did sham surgeries on a certain amount of people and then did meniscectomies on a certain amount of people. And these were people with arthritis. So those patients at 2 years essentially had the same outcomes. And so at that point, we realized, we probably should not be going into arthritic knees and removing the menisci. That the outcomes just, we're not making people's lives better. Now there's a deeper level to that. Well, what about the 2 years before that 2 year time point? I think in general, if you're like, okay, I know I'm going to need a knee replacement, I'm not ready to do it, and I want a little bit of relief, then yeah, it's not unreasonable to have a meniscectomy with the knowledge that this is not going to be a definitive procedure for you. So that's talking about patients with arthritis. In a younger knee that has no degenerative change and you're having meniscal pain, about 50% of those people are, if it's a degenerative tear, are going to be able to PT out of the meniscus pain, and the meniscus tear will still be there, but it'll become asymptomatic. And it sounds like you are in this group of people. And so that is why if you have a degenerative meniscus tear, we normally recommend trying PT first, maybe an injection, and seeing what your results are like. If at 6 weeks you're like, that's not working, my knee is still bothering me, then we go to surgery. There's no rush to do a partial meniscectomy because we are not preserving the knee, right? If you have a repairable meniscus tear, that again is a separate issue because we want to repair that meniscus to preserve your knee health, right? If you had an acute trauma and you come in and you have a meniscus tear from that, then that is one that I'm like, well, you probably should not pass go, do not collect $200 and go ahead and repair this meniscus, right? That goes straight to surgery. So, and I'm generally I guess I wouldn't say I'm conservative, but I'm not aggressive, right? That I really like to discuss what all the options are and always include non-operative treatment in there. And for a meniscus tear that we're going to treat with a meniscectomy, there is no rush to surgery. That in general, we can see how are you going to do with PT first? And many people can avoid surgery. And if you can, that's great, right? It's good for your pocketbook. It's good to avoid the knife at any points. No surgery is without risk, even a very simple surgery like a meniscectomy, which we essentially consider to be risk-free. There is the rate of complications is very low, but it's not zero, right? Martha, I see you had meniscus surgery a week ago, and how long to expect swelling in the knee? So again, depends if you had a meniscus repair or if you had a meniscectomy. With my patients who have meniscectomies, I generally tell them to expect about 3 weeks of noticeable swelling. That during that time period, the quad muscle will be a little shut down. You may have a little knee buckling and some swelling in the knee. Everybody's a little different, but ballpark tell people that they can expect to return to most activities in 3 to 4 weeks after a partial meniscectomy. A meniscus repair is a totally different beast. We put you non-weight bearing for 6 weeks because we can't stress that repair. You can tear through the sutures by weight bearing on it. And that is a much larger surgery. There's a couple different little flavors and varieties of meniscal repair. If it was there was an accessory incision, that's a much bigger tear, and you could probably expect swelling in the knee for at least about 3 months, and maybe even very subtle swelling for up to 6. Not like symptomatic swelling, but just like, oh, I look at my knee, it looks a little more puffy than the other side. So I think if it was just a scope, I'd say by a month, you should be pretty much back to normal. If it was a repair, then a little bit longer, probably 2-3 months, where you're noticing there's some swelling there. But of course, during that time period, it's continuing to improve. It's not swollen up like a balloon. Melvin, I see you had bilateral total knees 11 years ago, and that both knees are very stiff and hurt when you sit for a while. And you have extended PT. And about 5 years ago, you had one knee scoped to remove scar tissue without a benefit. So this is a difficult problem. That the painful total knee is kind of the blight of joint replacement, honestly. That, we generally expect a home run outcome after a knee replacement, and that when patients are stiff and when they're still having pain afterwards, it is a complex issue and requires a really good physical exam and further kind of workup. That normally going in and removing some scar tissue helps with range of motion and may help with pain, but there's a variety of issues why you may have a painful knee. Without getting into like overly kind of semantic detail, one of the things that we always rule out first is an insidious infection. But there are many little things that can be causing some pain after a knee replacement, loosening of the implants, etc. So this is definitely something that we would have to see you. Like we got to get some x-rays, get a good exam, see exactly what's going on, because this is a complex issue. Tom, is dry needling covered by Medicare? And I actually am not sure. Olivia, do you know, is dry needling covered by Medicare?
Unfortunately, it is not. Most insurances actually do not cover dry needling due to the lack of evidence-based research behind it. It's a fairly new treatment technique, so there's not, again, a lot of evidence yet. But we at Avalanche charge $20 for a needling session. We also offer a needling card, so it's buy 5 treatments, get 1 free. And in the county, honestly, that is the cheapest rate for dry needling. So yeah, if that's something that you're interested in, definitely get in to see us, because like I said, I swear by dry needling. It is truly a miracle worker.
Well, that's awesome. I did not know that. I'm going to be happy to pass that on to people, Olivia. Okay, Glenn, 56, you have meniscal concerns due to degenerative wear and tear type reasons. You're an ultra runner, I imagine, ultramarathon. And your knees, particularly the left, continue to hurt, but only during activity. Left knee particularly hurts during and after snowboarding. You don't see swelling, and is an MRI ultimately needed to really determine where the problems might be? What are some of the expected recovery? Sorry, this just moved on me. Recovery times, and return to trail running depending on repair or trim. And are you on the wrong track? And this could be a cartilage issue instead. Lastly, are there things I should try to on my own to mitigate the pain and prevent further possible damage? So one, yes, an MRI is ultimately going to clarify this issue. That an exam will be able to get a pretty good idea with certain special tests. Is this more of a meniscus issue, or is this some cartilage wear? My guess, it's hard to say. It could be a little of both, but that x-rays will also help clarify this, that if you come in and you get x-rays and you have loss of your joint space, we know that's a cartilage issue because you've worn out the cartilage and you're narrowing the joint. The expected recovery times and return to trail running depending on repair or trim. So trim, everybody is different, but I think not unreasonable to consider about 3 to 4 weeks. That, you know, I have aggressive skiers back to aggressive skiing after a trim at 3 to 4 weeks. Sometimes it takes a lot longer. I also have people who are very athletic and are coming back in for their 6-week visit after a trim, and they're still lagging a little behind. But like the trim is kind of the procedure when you see an NFL athlete has had a knee surgery and they're back on the field in 2 weeks, that they've had a meniscal trim. The repair is the meniscus surgery that takes them out for the season. So that I generally tell people it's going to be 4 months until you're back to these dynamic high level activities and it may even be a little bit longer than that. That it's 6 weeks of non-weight bearing out the gates, and then you're working on strengthening, really making sure you have that full range of motion back and getting back to more dynamic activities. By 3 months, should be feeling great. And I'm pulling the reins back on you a little bit just to make sure you're not doing anything to damage this repair. 4 months, I'd fully release you at all activities, but you may still be doing some additional strengthening about the knee in that time period. So I think a return to trail running at about 3 to 4 months on those, and that may change a little bit based on your follow-up visits. And I don't think you're on the wrong track, but yes, it could be a cartilage issue, and they are not mutually exclusive. And things that you can do to try to mitigate the pain and prevent further possible damage. So I never tell a runner who loves running to stop running, right? That's my job, is to get you back to doing the things that you love, right? There's a risk profile to every activity. Getting out of the bed in the morning has a certain risk profile. Getting in your car, right? So yeah, running may not be the best thing for your joint, but if you love it, you should keep doing it. And that's why we have joint replacements. That I think, do not stop running. You're not really going to do further damage to the knee per se. You may be causing some accelerated wear over the long course of time, but myself and many other people are in agreement with this. Keep doing what you like to do. Things that you can mitigate the pain, anti-inflammatories are a crux in my armamentarium. Olivia is like fantastic. That physical therapy is that is the number one non-operative intervention in physical therapy, right? Getting everything strong, using all the modalities that they have at their disposal, and that, you know, not every knee pain issue is a surgical issue, right? That we can get you back to sport frequently without having to go into the OR. Little things that people also ask me about: turmeric. Yes, natural anti-inflammatory. It's great. It's not as strong as taking an ibuprofen, but I think it's a great adjunct. There's not a ton of evidence behind fish oil, chondroitin sulfate, those sort of joint preserving things. But if you like them, take them, right? They're not going to hurt you. And people also ask about CBD directly onto the knee. Again, no evidence really behind it, but if it helps your pain, do it. You know, there's nothing wrong with it. Same kind of deal with acupuncture. People ask about that, that it's not going to necessarily change things, I think, but if it works for you, it works for you, right? Kathy, how does one know if it's knee, hip, or sciatica? So this is something that we would tease out in clinic, that sciatica is the great imposter, right? Because when you have nerve pain, it can cause pain in the hip, in the knee. It's due to compression of the nerve. So with special testing, we determine whether we really think this is a mechanical issue coming from those joints, or whether this is a nerve issue coming from the compression of that very important nerve. Big things that we key in on are: is there numbness and tingling? Is there any weakness down there? Are there other symptoms associated with nerve compression there? And then on the other side of that, is there a instability issue? Is there mechanical kind of clicking, popping going on in the joint? Is there a noticeable exam finding on the knee or the hip that points to the fact that this is coming from those areas? Normally, point tenderness around the hip or the knee points to the fact that it's a musculoskeletal problem. And then that kind of burning, vague pain is more indicative of sciatica, or maybe something coming from higher up in the spine. Rebecca, Oh, thank you. I appreciate the compliment on the great presentation. So your X-ray in January showed calcification in the knee, and can I say more about the cause and how to prevent further damage? So calcification in the knee can have multiple causes. There can be an underlying condition called chondrocalcinosis, where the cartilage is calcified. Also, if you've had a lot of steroid injections, that can cause some calcification in the knee. Just normal wear and tear can cause a little calcification too. One of the ways the body tries to heal things sometimes is almost trying to lay down a little bone where it doesn't belong. So could be any of those variety of things. Preventing further damage on this is, it's tough because it's just kind of a wear and tear type thing. I think going in, doing some physical therapy will not change the calcifications in your knee, but will change the pain generally. So it's difficult to prevent further calcification in the knee if it's there, but normally the calcification itself is not actually the problem. It's kind of the underlying, okay, is there a little cartilage wear? Is there a little meniscal tear there? And those are things that can be taken care of surgically, or that we can use our physical therapy counterparts or our little other helpful adjuncts, injections, anti-inflammatories to help modify the symptoms. But once you start seeing that calcification, there may be a little damage that is just done, essentially. It does not mean that you need a joint replacement, though, necessarily. Lynn, would I recommend wearing elastomeric knee braces during activity to limit range of motion? No, I think that if you are having, I generally don't like to limit your range of motion unless there's a specific reason to. I do think that like neoprene knee sleeve is great if you're like, know you have a little knee arthritis and you're getting some knee swelling and you're trying to combat that swelling. But I generally don't have a big problem with a full range of motion ever, unless there's a certain reason, like if you're post-surgical or if there is a impingement type issue, which is normally in the hip, that I don't like people really just trying to, quote, stretch things out when they're really just driving their bone against bone. But I think I never have a problem with patient wearing like an elastic type knee sleeve, but I don't think with the goal of limiting range of motion, I don't try to limit people's range of motion. I want you to stay flexible and I want you to have a nice full range of motion. Anon, I think part of your question got cut off here. I just see age 57. So if it pops up further down there, I will answer you. Amy, I also think maybe part of your question got cut off that you have had Synvisc and steroid injections. I'm not sure what the question is there, but there are other options than Synvisc and steroid if that's the question.
Dr. Seiter, I think that some of their questions were before Lens.
Oh, okay.
I don't know. I think it scrolled quickly again.
Hang on, I'm missing it. I see Gail, I see Tom up there. I don't see Anon and Amy. Am I missing it?
It goes Tom, William, and then Amy, and then Anon.
Oh, would you mind reading the question? I'm just not.
Oh yeah, sure. So Amy asked, age 61 skier with knee pain from Patellofemoral Syndrome. Would PRP or stem cell help, or just buy time before a knee replacement?
So the major downside to biologic injections is the expense. That they are a great treatment. I think they're not a miracle worker. And if anybody tells you they are, and my partner who does them here is Dr. Nurki, and he does not, there's no smoke screen or anything. It's not a miracle thing. That there is a clinic in town where they kind of are a little snake oily and they're like, oh yeah, this will regenerate your arthritis. It won't. That there is the potential for a healing response with a stem cell injection or a PRP injection. How we regard them in our orthopedic literature and as kind of astute you know, well-read individuals is more of an anti-inflammatory type treatment that yes, we do use them with certain tendinopathies and expect them to have a healing response. In response, when we're talking about cartilage, though, cartilage regeneration is if you could open that box, you would be a miracle man, because we don't have anything that can regenerate cartilage, which is why we do these cartilage replacement procedures. So I do think the juice may be worth the squeeze. But they may function more similarly to a Symvisc or a steroid injection that you've had before, right? Cooling down the inflammation in the knee, maybe doing a little healing of some of the bone underneath the cartilage, but it won't give you new cartilage. So in that sense, yes, maybe it's buying you some time, but you know, I will see patients sometimes who are like, yeah, I had that BMAC injection, and BMAC is stem cells, and it gave me 4 years of relief. And I had been getting steroid injections every 6 months before that. So everybody responds a little differently. And the biggest risk is the risk to your pocketbook, because they're not covered by insurance. But overall, we do not feel that they degenerate the joint, which the steroid may do. More so if you're getting repeat steroid injections over a long course of time. But so I think they're great, but I use them with reservation because they're expensive. And
yeah. His says, I was hit by another skier and twisted my knee 4 weeks ago. Was off the slopes for 2 days, but gradually built up to skiing full days with 30K vertical. Still some pain and hyperextension and flexion. If I squat and go into extension, some temporary pain that goes away. Generally, the knee has gotten better with time, but not worse. Should I seek treatment and imaging, or wait for end of season and let it rest for a few weeks?
So Anon, I like, there's nothing there that like jumps out at me, but getting hit by another skier, I've seen a lot of bad injuries from this. You're crushing it. 30,000 feet vertical is not a small amount. So it sounds like you're functioning very highly. But I think it's a little bit of a dealer's choice. Like, are we going to find something if you come into clinic? Quite possibly. Is it something that is time sensitive? The story you're telling me makes me think no, because you are functioning at an extremely high level right now that, you know, I have friends who have trouble getting 30,000 in a day. So I think, you know, we are always happy to see you, and I don't think we will sideline you for the rest of the season. So I would actually say come in and see us, you know what's going on, right? No one's half the battle, and we can reassure you, or if it is a problem issue, then we can pump the brakes on you. But in general, I think, you know, coming in to see us and get to the bottom of it, it's a zero risk thing, other than, you know, an hour or two in clinic. Okay. And Diane, what are the treatment options for Patellofemoral Syndrome? 72 active and 5 foot, 115 pounds. So PT right off the bat. That I will, if you come into my clinic, I'm sending you straight over to see Olivia. I may offer you an injection based off how symptomatic you are, and if we think that you're going to have some trouble progressing with PT because of the pain you're currently having. I generally like to try to keep that injection as an arrow in the quiver and see if we can make some progress with PT first, and then have you have an injection in case you're stalling, or if you're like, it's just not working. But I also am not, you know, I'm not a sadist. If you're like, I'm not going to be able to do PT, we're going to go ahead and get you an injection there. So PT right off the bat, if you have failed a long course of PT, then we start talking about things like resurfacing the patella or a total knee replacement, other things like that. And then again, biologics are another injection that is a good adjunct, but as I said, the price is the issue with those guys. Lisa, I see you have a full thickness radial tear involving the lateral meniscus. That's a bad injury. Are you still able to ski? Your knee did swell some this year while skiing, and I'm worried you will do more damage. Would I benefit from wearing a brace while skiing? So I'm worried you're doing more damage to your knee as well. Radial tears are the kiss of death when it comes to the meniscus, that they generally do not respond well to a repair, although depending on your age, I will try to repair a radial tear. We have some special techniques to try to essentially like do a rebar style repair in there to get that thing to heal and give you a functional meniscus. The thing that is a real bummer about a radial tear is you disrupt all the circular circumferential fibers about the meniscus. So I just drew a radial tear on there, right? And if you have a radial tear there, the entire meniscus can become incompetent because the meniscus just gaps when you're placing weight on it. So the cartilage starts to see a lot more force, and it's can really lead to some quick wear of the meniscus. However, if you are a certain age, and the knee is not like really bothering you and you're able to get around and ski, then, and we're just going to trim out that radial tear, then I think getting in for some PT may be able to quiet this down. And you just know, hey, you know, I have a problem that can't be fixed within the knee, and hopefully my knee holds out. It's never an issue. That certainly happens with people. And then some people progress to more rapid arthritis and need a definitive procedure, which would be knee replacement. So and wearing a brace while skiing, yes, I actually do think that can help you quite a bit. The brace that we use for these type issues is called an unloader brace. That will cause the cartilage to see less force. It's not a brace you want to wear all day long because it's a forceful brace that pushes your knee into a position that is, you know, it's pushing on your tibia to unload this cartilage area. But some people don't tolerate them that well. You know, the people who like them the most are the golfers, because they'll go out, wear it for 4 hours. When they walk the course, it unloads that area. Skiers, some people love them when they're skiing. Some people have them trouble getting them fit over the ski boot. But generally we can work that out. And so I think actually, yeah, wearing a brace may really help you. And I think you should come in and see us. That would want to prevent you from having more knee damage if possible. And if it's something we're just going to live with, I'd want to get you in some PT and get you into a brace. Jim, I see you have arthritis on the kneecap and you have swelling that does not go away. You've had a steroid shot and one Symvess shot. That's helping with the pain, but not the swelling. The knee aches all the time. The knee is stable. What next? And you're 77, and can the kneecap be abraded to help? So I think honestly, if you are finding the swelling to be problematic and it's limiting your function, then it's not unreasonable to consider a joint replacement. Kneecap abrasion, so abrasion arthroplasty is also known as microfracture, et cetera. That is something that we do when you're young, and it's a very focal defect that in your case, I think either a partial or a total knee replacement, depending on the condition of the rest of your knee, would be the surgical option. But other options are therapy and continued steroid shots. But if those aren't working for you, then it's time to start thinking, okay, maybe I want to have a definitive procedure on this. Cheryl, I see you have a large 92-pound dog which pulled you down on a walk, jerked you around about 180 degrees and drug you on the ground. I'm sorry that happened. That sounds terrible. That your knee pops in and out and catches and is painful. Got an x-ray and MRI, and doc said nothing was wrong structurally. Started PT to see if this helps. Should I go for a second opinion or just continue PT and see what happens? So I think it's totally reasonable to have a nice 6 to 8 week course of PT. I expect that you will have some nice improvement. I'm not sure what you mean by knee pops in and out, but that catching that kind of makes me a little curious of, is there a little cartilage damage there that somebody didn't see on the MRI? Or is there a little meniscal issue in there? So I think it's totally reasonable to have it a second opinion. I think you go either route, do 6 to 8 weeks of PT and see how you're doing. Or if you're like, you know what, I want a second opinion today, just come in and we'll give you a second opinion and see exactly what's happening. And if there is a structural issue, it can be addressed, versus if it's something that we think you're going to be able to PT out of, we'll keep going with that course. But I don't think I think you're probably okay to keep going with the PT. 6 to 8 weeks is generally what I tell people is like a general benchmark where we expect to see some improvement. And if nothing's getting better, then I think it's definitely time for a second opinion or following up with the original doctor. Dawn, so your dad is 86 and x-ray shows the bone looks good. He does not have bone-on-bone arthritis, but he has pain and swelling inside the knee, weak and unstable on that leg since Christmas, difficulty sleeping comfortably, no trauma to the knee. And the ortho thinks it's degenerative meniscus. He had PRP with no relief, now doing PT, somewhat painful and Voltaren. Next recommendation is cortisone injection. Recommend an MRI. Yeah, I would get an MRI. I'd want to know what's going on inside there. I think I would follow the exact same course of treatment. I may have done the cortisone injection before because, again, as I said, the expense thing is something I always talk about with patients. But this sounds very reasonable to me, and I think that is pretty much by the books. But I think getting an MRI, again, no one's half the battle, right? Is it a meniscus or not? MRI will tell us. Barbara, if meloxicam is working for minor knee problems, how long is it safe to take the medication? Indefinitely. I say that with some reservations that, I don't want you knocking out your kidneys. Anytime you're taking meloxicam, you got to make sure that you're well hydrated, and you got to make sure you take it with some food so you don't cause stomach irritation. But people take meloxicam for years on end. The reason why we prescribe meloxicam rather than telling people to take ibuprofen is it's more stomach protective. So it's generally a little more well tolerated over a long period of time. So I think taking meloxicam for a long period of time is no problem at all. And if I'm going to prescribe somebody a anti-inflammatory that I'm planning for them to take for a while, meloxicam is my anti-inflammatory of choice. So anonymous, what issues respond to PRP injection? So I touched on this a little before. Things that we expect to heal are going to be more tendinopathies. The best evidence for a PRP injection is tennis elbow. There's some good evidence for it on proximal hamstring and patellar tendonitis as well. So that's when we're like, yeah, this PRP is really going to benefit you. Inside the joint, we expect it to function a little more like an anti-inflammatory. There's also some good evidence for PRP injections for partial thickness rotator cuff tears. It may induce some form of a healing response there. Theoretically, it should. It hasn't borne out as much in the evidence, although it's been a little proven in the clinical trials. So best indications are for tendinopathies, maybe a partial thickness tear. And it's very good as an anti-inflammatory, but you should not expect a bunch of cartilage healing from the PRP injection. Although they are great in the joints, people swear by them, and I think they do work very well. Dawn, thank you for the compliment. I appreciate that. Anonymous, is stem cell use for knee injury being used? Yes, absolutely. So the stem cells that we generally use, you've probably heard about amniotic stem cells, and you've probably heard about bone marrow aspirate. We like bone marrow aspirate. It is your own tissue, and that has, it's the closest to your own anatomy, right? So with that, we take a little trephine, which is just like a little trocar that we put into the bone, and the best stem cells are in the back of the pelvis. So we take that, we spin it down and inject it into the knee. The amniotic stem cells and the fat stem cells are also being researched right now, are more commonly used by like stem cell clinics. If you're coming to an orthopedist, we like that BMAC, and the evidence is very good behind it. but again, it functions similar to PRP, maybe a little higher strength because it's a little more concentrated. But yes, very common for knee injuries. Issue is the out-of-pocket expense. Lisa, PRP or knee scope for minor meniscus tear, both sides of the knee. Dealer's choice, Lisa. That I think if you are wanting to try to get out of this without having to do any surgery, a PRP is super reasonable. If it is a repairable meniscus tear, that's when I would nudge a little bit more towards surgery. But if it's one that we're just talking about a meniscus trim, PRP plus PT, because PT is actually going to be the more important component of that. That the PRP is going to help with some anti-inflammatory things, but you got to get the knee strong. You got to work on all the other components around the knee, and therapy is the crux there for making that meniscus pain go away. And therapy, if it is a degenerative tear, is a zero loss thing, right? You know that you try it, hopefully it works, and in the majority of people, or the half of people, it will work for this, and you'll never need surgery. And anytime I can have you avoid surgery, I'm actually kind of happy, although I love doing surgery. Jana, after a total knee, what's realistic in terms of recovery, time-wise and moving-wise? Everybody's different. Some people wake up and are just crushing it from day one. Some people lag further behind. I tell people a total knee replacement is not the same as a total hip replacement. Total hip replacement, people are like really quite functional at 3 months. With a total knee, you're getting your range of motion back at 3 months. That's when you're starting to get that full range of motion. And if you don't have full range of motion at 3 months is when we kind of start to worry. Range of motion is generally the first thing in our kind of therapy sequence, right? So after that range of motion is back, then you're really working on strength, and you're working on it during the same time period. A total knee is stable from day one, but I think generally you should expect 3 months, be feeling pretty good, being satisfied you did the procedure. 6 months, quite possibly pretty close back to normal, but continuing improvement up to a year, sometimes even 2 years, depending on how long the condition has been pre-existing. Cole, I see you're 27 and you had a bucket handle meniscus tear 3 years ago with an impingement in the knee. So this is the worst type of meniscus tear, a bucket handle. That you had surgery and the surgeon sutured the section in position. Good. These are the types we like to repair. More recently, you've been noticing inflammation and occasional pain near the site of the original injury. You visited with the doctor and currently receiving PT. Neither physician felt that an MRI would be necessary. If my injury does not improve from the PT, would an MRI provide enough resolution of the meniscus to differentiate between a tear and scar tissue from a previous injury? I see you must have been doing some reading or talked to somebody about this, because yes, that is one of the things that we worry about is, are we looking at a healed tear here, or are we actually looking at a true tear? I think an MRI, I probably would have ordered an MRI on you upon seeing you if you were telling me I'm having pain at my previous repair site, right? That if there is a big old tear there again, we will see it, right? But when it gets into the gray area, they do the route of sending you to PT. I don't think sending you to PT off the bat was the wrong decision, though, because when you have a big tear, generally, if it doesn't heal, we're going to talk about trimming it out. That yes, a revision repair is a possibility, but it has a much lower rate of success than the initial repair. So I think MRI, if you came and saw us, I'd order an MRI on you tomorrow. But I think if it's not improving from PT, MRI is a must. You got to know what's going on inside there. And it may be a little wishy-washy based on the results of the MRI. It may be clear cut too, but MRI is definitely the next step. And then talking about a revision repair if it is torn, or trimming it out if it is torn, or just other things, maybe a little injection or something like that, or continued PT to try to get the pain to go away. Arthur, I see you can't run without severe pain, and your knee has been scoped 3 times. It hurts all inside the knee, and sometimes just while laying down. Also gives out sometimes. Like and sometimes hurts under the kneecap, and the quad gets pretty tight biking or using the total gym or squats. And sometimes the back of the knee hurts or feels weak, and it's that you get a burning, tightening in the calf, like a cramping or a knot when in the belly of the same calf. Sitting, the knee hurts as well. You've been trying to strengthen the leg muscles, but can't ski, jump, run, or bike easily. So I think this, I'd have to see in clinic, to be honest, Arthur, that it's tough to know. This is something that, like, actually, you're one of the people that imaging is really going to help sort this out. That is there a ligamentous issue? Is there some cartilage wear? Baker's cyst, we generally think of as more of a secondary thing, that there's something else going on inside the knee causing swelling and leading to that Baker's cyst. So we want to treat the underlying problem that's causing that cyst to form in the back of the knee. So I think, there's nothing wrong. It sounds like that there's nothing wrong with you starting up some PT, and that would probably be my initial suggestion based upon seeing you, but it's hard to know exactly without getting a good exam on you and getting some good imaging on that knee. Oh, and I see Dr. Cunningham has worked on the knee and you're bow-legged, and that laying on your same side hurts inside the knee also. So this is sounding a little more like arthritis already. That when you start to get a progressive bow leg, that means you're having a little wear out of that inside of the joint. So Cunningham's awesome. And I think if he has said, you have some arthritis, or if he said you don't have arthritis, I would believe him. And that I think, getting in some PT to try to strengthen around the knee, like, you can do a bunch of stuff in the gym, but they are the specialists. They are very good at focusing in on the problem at hand and working on the deficient areas. That I think getting some PT going is probably where I would start. But that, based off all the things you say, you may have some frank arthritis. And if everything bears out on an exam and imaging, you may be a candidate for a knee replacement. But tough to know. So don't tell Dr. Cunningham that I said you need a knee replacement if you see him, and then he's like, Max is crazy. Okay, so Dustin, you tore your ACL a year and a half ago, and you popped your knee but continued low. Besides the times that whole year, you can snowboard at a pretty high level, plus other things like biking. Also does not hurt. Should I continue surgery like recommended? I would fix your ACL. It's a personal decision to have surgery, right? The reason why we fix people's ACLs is to get them back to that high level of activity without having these sort of symptoms where the knee is unstable, right? It sounds like you're functioning quite well, but you're probably doing some damage inside the knee. That knee popping out, every time that happens, you're risking a big meniscal tear. You're risking further damage to the cartilage, early arthritis. As a young, and we see this in the shoulder a lot too, right? People will have like 20 dislocations in the shoulder, and then you're 30 and you're frankly arthritic. And that's a bad problem. Yes, do I think you're functioning very high at a very high level? Absolutely. And I think, if you were like, I do not want ACL surgery, I don't want to be laid up for that period of time, then we could give you a brace. And I would definitely at least consider coming in to see us so we could get you a brace, or we could talk about reconstructing your ACL. But, that worries me when I see your description there. And for example, I just took care of somebody last month who, she injured her knee about 4 years ago, never saw anybody. I thought she maybe had an ACL tear, but was like yourself, skiing at a very high level. And then boom, had another ACL type of handle meniscus, fix up her meniscus, and then reconstruct her ACL. And if you can avoid having a bucket handle meniscus, you have served yourself well, because they don't always heal. And when you have a big meniscus tear and then you lose a big part of your meniscus, it's not good for your long-term knee health. So For the goal of long-term knee health, I would say yes. I would recommend an ACL reconstruction. It sounds like you've returned to a very high level of function. Some people aren't able to do that without an ACL. But yeah, my recommendation would be for an ACL reconstruction. And I would use your own tissue because you're a pretty high level guy. Rebecca, thank you for the compliment, Rebecca. And oh, actually, I think, did I answer this one? Yes. Can I say more about the calcification? Oh, and you had a microfracture in 2009. Is this procedure still used? Yes, some people do. We have trended away from microfracture because the results are not as durable as a cartilage plug. And we know that after a microfracture, cartilage plug is not quite as effective. So yes, we still do it. Personally, I do not do it in the knee because I think there are better options, and I don't want to burn any bridges for you. That if you have a big cartilage lesion, I'll trim it up and I'll tell you, okay, we're going to see how you do. And we know that you have this big pothole in your cartilage, and I am ready to put a cartilage plug in there any day for you that you decide you are ready. So I think there's nothing wrong with doing a microfracture, but we know that the results after 2 years are not that great. And that's just something we've discovered in over the course of time. Anonymous, you have bow-legged malalignment at 65 years old. Is this likely a full replacement, or is there another solution? Likely a full replacement. That normally means you've worn out the inside of the cartilage. That does not mean you have to have a joint replacement, that we can go with non-operative routes. But at 65 with bow-legged alignment, common things being common, you've got some frank arthritis in there. But a simple x-ray and a simple exam will let us know exactly what's going on, but likely a full knee replacement. And Rebecca, more about meniscus repair and arthritic knees. So meniscus repair and arthritic knee, questionable. The goal of meniscus repair is to prevent arthritis, right? And or prevent, the progression of arthritis. So if it is very early arthritis, yes, I will repair a meniscus, particularly if it's a meniscal root. A root is just like it sounds. It's like the roots of a tree. It attaches the meniscus to the tibia. So in those scenarios, I will do a meniscus repair to protect and try to preserve the overall knee health. If it is frank arthritis, no, I will not. That at that point, we know the juice is not worth the squeeze, that you're going to be non-weight bearing for a long time, and it's not going to affect your pain, that the pain is coming from the arthritis at that point. Ron, supplements for knee inflammation, turmeric, ginger, glucosamine, chondroitin. So those are actually the 4 that I kind of recommend. I think another thing that I tell people about is an antioxidant diet. You can check that out on the internet. And it is like kind of a diet high in like blueberries, those sort of things, foods high in antioxidants. And people generally see a pretty good response to those. It does require a lifestyle change that some people don't want to do. I will actually eat a hot dog from the gas station sometimes. So, I sympathize with people who are like, I don't want to do that. But that I think glucosamine and chondroitin are the things that compose your joint fluid. So that's the idea behind those. We haven't seen great evidence as to those really helping, but turmeric and ginger are good anti-inflammatories. I think those are great if you don't want to take any NSAIDs. Fish oil, some people swear by it. Some people can't tolerate it because it's kind of gross. That also has a little bit of evidence behind it, but those are kind of the real crux of everything there that I recommend to patients if they're looking for kind of an all-natural thing. And then again, people ask me about CBD oil, and I tell them, knock yourself out if it helps you. That I don't actually see it being a truly evidence-based, but some people swear by it and they want to give it to their pets too. So, I see that you have anonymous. You have difficulty walking down the stairs or downhill, apparently because of a problem in your knees. What might this indicate, and what might the problem be? You are sounding like a patient with Patellofemoral Syndrome. This is very common. When you flex the knee, your kneecap sees 12 times your body weight in force. So Going downstairs is the classic symptom with Patellofemoral Syndrome. And this is normally indicative of a little patellar maltracking that we would want to treat with getting your quadricep and your VMO super strong again to really get that to track as normally as possible. This normally responds very well to physical therapy, although it just takes a little bit of time to really see the results because, as you know from going to the gym, it just takes a little while to get stronger. Ron, recovery after patellofemoral partial knee replacement. So I think a little quicker than a total knee replacement, but not that much quicker recovery. That I would expect at about 3 months for you to be doing quite well. That if you weren't doing quite well, I'd have a little concerns like, oh gosh, what's going on? Time to return to cycling and skiing after a partial knee replacement. So that is really based off your range of motion and your strength. There are no firm restrictions after a knee replacement. Everything is super stable. Like, we don't want you to go out and ski and cycle when the wound is still healing, because if you dehiss that, that's a real problem. But after the wound is healed and based off your range of motion and strength, if you're doing great, there's no restrictions on how quick you can get back to those activities. The average person is not going to back to those in a month, but that the hard and fast restrictions, like if I fix a fracture, we're waiting on it to heal, right? That there's no waiting to heal with the bone after a knee replacement. Everything is solidly in there. So it's based off your range of motion and your strength. And I would say most people may be able to return at 3 months to a light level of those activities, gradually building up the activities. I never want to create false expectations, anybody, and it may take up to 6 months to get back to some of those higher level things. But stationary bike is one of the things that we love for you to do. So cycling represents that, right? So cycling may be a little quicker than skiing, whereas skiing is a very dynamic activity that may take a little longer to get back to. And CB, I see in the early 80s, you had surgery that had been referred to as a cartilage tear and a meniscus tear. It was removed, not repaired. Beyond an MRI, is there any way to determine if it was meniscus or cartilage? The records are long gone. So yeah, an MRI is going to be the most definitive thing. That in the early 80s, we were not doing a bunch of meniscus repair. That, the evidence was just starting to come out that we shouldn't cut out people's entire meniscus, which today would be malpractice. But my father had a total meniscectomy in the late 70s, so it wasn't that much earlier, right? But the MRI would be the best way to determine, and that an exam will certainly help clarify things, but MRI is going to actually be the truly confirmatory thing. An X-ray may tell us enough, honestly, that if there's frank arthritis on the X-ray, we don't even need to jump to an MRI. Okay. Let's see. Okay, I just, thank you for the compliment, Anon. That's very nice of you. Rebecca, can I comment on some recent research that shows that moderate running may help prevent or delay degenerative knee conditions? I cannot. I could probably look some up, and if we see you in clinic, I'm happy to discuss it. But I don't know anything particular to running. There is research saying that staying active may help prevent any degenerative knee conditions, that when you are low activity, you lose bone mass, etc., that those things, having an active lifestyle within reason is will help prevent a degenerative condition. Some people love running and they're going to do ultra marathons. Maybe not the best thing for your knee health, but again, not anything I would ever tell people not to do, that you got to do what you love, right? But yes, so a general level of activity is good for your bone health. It's good for your overall health. It's good for your joint health. Running is a little dicey. People get worried because it's impact activity. I do not really worry about moderate running, though. I think that it is just fine. And so I don't know any specific research, but I'll take a look into it just for my own curiosity as well. Amy, And I see that you had I don't know what TPF is, but 14 months before tibial plafond fracture, meniscus, and 3 surgeries on the knee, and you haven't been without pain. Oh, so Amy, tibial plafond fracture is a bad injury. And even when it's perfectly reconstructed, they can just be really nagging problems. So it's never an injury that we like to see pop up because we know it can be a long road for the patient ahead. And commonly, if you had a high enough energy injury to have a plafond fracture, you have an injury somewhere else, and it sounds like you injured your knee there. I think that, without knowing exactly what's going on in your knee, it's hard to know what the best solution would be, but that I think, there's always some sort of option. The question is what is the best option? So I think, being seen in clinic is the really, I couldn't tell you much more without seeing you in person or one of my partners seeing you that, when I see that. So I think, keep trucking those tibial plafond fractures. You continue to get better up to 2 years out from the surgery, so it's a long road on these guys. And as for the knee, I'm happy to see you any old day if you want to sort things out. Let's see, did I miss anybody here? Oh, thank you, Rebecca. That's very nice of you. And I see we had some questions in the chat here. I just want to see if I missed anybody here. Okay, I think we got to Arthur, and I see Jamie had a question. Is it something that is genetic, meaning if your brother and your mother have had this problem, am I more likely to have this? Yeah, so things can be heritable. That's super broad, though. That I think, yes, there are certain heritable conditions, but that most orthopedic things, speaking broadly, are not necessarily heritable. It's more what we do in our life that causes the issues. Some things, yes, like hip dysplasia, which is something I treat in the hip, there is a heritable source. That does not mean that your mother or your brother have had that, but yes, that there are certain heritable things, and that's a broad answer, but it's a little bit of a broad question. So I think yes. And Glenn, okay, we touched on these questions, Glenn. Excellent. Rosie, did I get to your question there? Hopefully, I think so. Yeah. Okay. Linda, you had a total knee replacement in October, and your other knee is bone on bone, and Dr. Kafferke recommends a total knee when you're ready. You're reluctant and have not yet tried hyaluronic injections yet. Do you think this would help? So if you're bone on bone, we start to see a really diminished effect from the injection. So Dr. Kafferke is a very thoughtful guy, and I really respect his opinion. So I think if he's saying it's time for a total knee replacement, I agree with him, that you don't lose anything by trying an injection, but we wait 3 months after injections to do a replacement. So you do lose that 3-month period if you're like, oh my gosh, this just got so bad, I can't stand it. You have to wait 3 months because we wait for the risk of infection. Okay, Dustin, we got to you there. Dave, yes, Dave, a meniscus tear is something that can be expected in an 80-year-old. And I believe Rachel is going to get us set up for a replay of this session. And as we get older, if there's no arthritis, I think a meniscus tear can be surgical, but it would just be a trim. So we would definitely try some non-operative stuff first. Guy, you have a full thickness lunge lesion on your femur, under your kneecap, and you're 46 and it still hurts when you surf in the patellofemoral compartment, full thickness chondral fissuring the patella. I think you might be a candidate there, Guy. So I think in general, but I think, you know, as long as the rest of your knee looks pretty good, you would be a candidate for myself. And I'd like to meet you in person, but I'd be happy to get this taken care of for you. That you sound like you're a candidate. Also, we would. Um, okay. Hey, Peter, I see you had a skiing issue with knee popping, and you are 72 and moderately active. You ski bicycle. You posted this at 5:30. Oh gosh. I am missing the question here. Do you see it on there, Olivia? I'm gonna, if you don't mind, Olivia, if you can see if you can find that for me, I'm just gonna keep moving down the list here. Yes, I don't know if I'm mispronouncing your first name, and I apologize if I am. But anonymous 50-year-old, a couple years ago, I had a full thickness rupture of the PCL and a grade 3 MCL tear, PT with no surgery. After skiing, you get pulling in the patellar tendon for 20 minutes. Should I keep skiing or more PT? Biking doesn't hurt as much. So you have a tricky knee issue there. That this is something that I would have probably non-opt on you too and see how you do, right? Because it's a big surgery that we'd be doing, and PCL ruptures can do pretty well non-operatively. In combination with an MCL is when, okay, now you've got a multi-leg, so now we've got a problem, but I would have braced you, had PCL heal in. As long as that is stable, I would let you return to your activities. It does sound like maybe you're having some instability, and I think it's pretty reasonable to be seen for this because I'd want to know exactly what's going on inside your knee. I think continuing to ski with a brace, because I'd probably want something protective on you, because it does sound like you may be having some instability that's causing that pulling on the patellar tendon. But I think you're never going to hurt yourself by doing more. Biking is generally an activity that you don't need knee ligaments for. Because it's all linear, right? And your foot's on that pedal. But it sounds like you may be having a little issues. I wouldn't have treated you any different, but I would want to know exactly what's going on inside your knee. And it may be something that, you know, you may benefit from some surgery or, you know, just continue with PT. I would never tell you to stop skiing, but maybe consider coming in to see us to get a brace, and let's just see what's going on. Martha, thank you. That was very nice. Shelly, you have quad tendinosis and had a PT, PRP injection, dry needling. What more can I do? Quad tendinosis can be a real nagging, like lingering thing. You're checking all the boxes right now, Shelly, that you've done the right stuff. PT, PRP, dry needling, that's exactly what I would recommend. So it would depend on the time frame of this, that if this has been going on for quite a while, then you are, you know, you've met the indications for surgery, right? You've jumped through all the conservative hoops. If you're not getting better with that, then it's like, okay, we can consider doing a debridement and taking out a little of that inflamed and degenerative tissue and all the good tissue back together. And that's actually not very morbid. We take the quad graft for an ACL all the time, and we take out the middle of people's quadricep tendons. But I would encourage you that this is just something that takes a long time to recover from sometimes. So don't give up on it. Keep going with the PT. Keep working. If you want to come see me or seeing them, that normally will really let people go a long time I will recommend an operative tendinosis type condition. That the improvement is slow, but if you're starting to see improvement, know that that is a great sign that I would expect you to continue to improve, and it just takes a while with these. And it's a bummer, that it just hurts, and the progress is slow.
That's Peter's question.
Oh, Peter, okay, that you can walk fine with no pain. You have some stairs, some pain, not too much. Skiing, the knee is popping, and then when you stop, very painful to walk in ski boots. Gets better quickly in regular ski shoes. So I think, I don't know, it's hard to know off that description, Peter, that I'd really have to get an exam on your knee to know exactly what's going on. Pain and popping generally points to me towards some meniscal pathology. I think walking in the ski boots is probably because, your gait is so changed when you're walking in ski boots, and then you're able to compensate better when you're walking in a regular shoe. So I think if it's bothering you, I'd want to see you, because I'd want to know that you're not doing more damage to the knee when you're out there skiing, and I'd want to keep you skiing. Sorry if that's kind of vague, but it's hard to know. Okay, guys, I think that is all the questions. Olivia, do you think I missed anybody here?
No, I think we covered all the ones in the Q&A and in the chat.
Kathy had one final one here, it looks like, that can a hip and knee be replaced on the same side in one surgery? I'm 73 athlete. I wouldn't recommend it, Kathy. It's better to stage these out. The recovery on each is different, and you don't want to risk the overall success of your surgery because you're not able to compensate between the two. That if you have a knee replacement and then your knee is stiff afterwards, you don't like it. And it's better to just, I would do the hip first and then the knee. That's my recommendations on these, because the hip, you're going to bounce back a little quicker, and you're going to be able to rehab the knee more effectively. You don't want the hip holding up your knee rehab, because the knee rehab is harder. Amy, I see you had a tibial plateau fracture. Man, you had a bad injury. So hang in there. There are options. There may be a little more surgery in your future. I can't tell you without meeting you, but that's a big time injury you had there. So you can expect a long recovery, and keep your head up. That I've got a lot of patients in the Vail Health Hospital right now with a similar type of injury, and it's a long road. So it just takes a while. Okay. Hopefully we got everybody, guys, here. I really thank you so much for tuning in, and I really enjoyed this evening, and thanks for all the questions. And hope to see some of you guys in clinic, and hope y'all are able to get out there on the mountain before it closes up.
Absolutely. Thank you all again. And same. Hope to see you out and about, and hopefully not in the clinic, but if so, we're here for you.
Thanks, Olivia.
Thank you.
Bye, guys.